everyone. My name is Mirvat Alasnag, and I'm an interventional cardiologist practicing in Jeddah, Saudi Arabia. Today, I'll be discussing the MitraSwiss Registry, which is one of the late-breaking clinical trials presented at the European Society of Cardiology's annual conference 2022. And with me is the first author, Luigi Biasco, for PCR Online. Hi, Luigi.
Thanks for having me.
Well, thank you for taking the time to be with us today. So I'm going to quickly dive into the first question. The MitraFR showed results that were not consistent with those in the COAPT study. And upon closer inspection, we see that the population enrolled in the MitraFR were considerably different than those in the COAPT. So from the MitraSwiss Registry, is the population enrolled similar to that of the COAPT or the MitraFR cohort?
Yeah, thanks for this question. You know, it's always different to compare different populations. Our registry was an all-comer registry designed to enroll patients with both primary and secondary mitral regurgitation, with a good balance in between the two etiologies, because we have 50% of patients with primary mitral regurgitation and 45% of patients with secondary mitral regurgitation. Well, for what relates patients with secondary mitral regurgitation, our population is much close to the population enrolled in the COAPT trial rather than to the population enrolled in the MitraFR trial. As a first, our median left ventricular and diastolic volume in secondary mitral regurgitation patient was 163 millimeters, classifying our cohort as patients with predominantly disproportionately severe mitral regurgitation. When considering surgical risk, our cohort showed low STS and Euroscore 2 score than the patient enrolled in the COAPT and the MitraFR, with a median STS and Euroscore 2 of 4. When analyzing the survival, 12 months mortality in our secondary mitral regurgitation cohort was about 15%, while 20% in the COAPT and 24% in the MitraFR, despite a mean age older than the patient enrolled in both trials, because in our registry, mean age was 76 years, while in the trial was about 70 years.
So, what were the inclusion criteria for the Swiss registry in terms of, pressure, pulmonary pressures, LV dimensions, etc.?
The only inclusion criteria used to enroll patients in the MitraSwiss was being a patient symptomatic with moderate or severe mitral regurgitation, in whom TEER was deemed indicated according to the European guidelines at the time of patient enrollment and after confirmation of clinical and technical suitability by our team. Overall, in our cohort, 78% had pulmonary pressure greater than 30 millimeters of mercury, and the mean left ventricular and diastolic volume was 136. We did not collect data about ERWA.
Okay, so it seems like it was real-world data kind of collected. The Swiss registry aimed to capture long-term survival in those receiving transcatheter edge-to-edge repair therapy using a novel concept of relative survival that adjusts for background mortality risk in the general population. And it generally permits cause-specific estimates. So can you please describe the design of the MitraSwiss registry and the primary and secondary endpoints?
Yeah. The registry was designed in 2012 in order to prospectively collect consecutive patients undergoing percutaneous edge-to-edge mitral valve repair with the MitraClip system. It was originally designed to enroll 1,000 patients and to obtain 5 years follow-up. The target was reached in 2019, and now enrollment is stopped while follow-up is still ongoing. Starting with 4 centers, as for today, 10 centers are still continuing the follow-up of the patient enrolled. And in 2012, we enrolled 1,200 patients in the registry. The data collection is centralized in Cardiocentro Ticino in Lugano. Given the availability of this large data set of patients, as well as the possibility to obtain national mortality tables from the Swiss general population provided by the Swiss Federal Bureau of Statistics, we decided to design this study based on relative survival, which is a statistical tool to compare observed mortality in a cohort of interest to the expected mortality in an age, sex, and interval-specific match group derived from the general population. Basically, this approach quantifies the excess mortality given by the specific disease of interest, in our case, mitral regurgitation. Our primary aim was to assess survival of enrolled patients treated by TEER while adjusting for the underlying expected mortality risk within the Swiss general population. Additionally, we aim to assess the impact of mitral regurgitation etiology, age, class, and procedural success after TEER on procedural life expectancy.
So were there any notable differences between the restoration of life expectancy in those with primary mitral regurgitation compared with secondary mitral regurgitation?
Yeah, this is a crucial question because overall 5-year relative survival estimates attained at 80%, meaning that basically patients treated by TEER showed a 20% excess mortality as compared to the general population. In patients with primary mitral regurgitation, 5-year relative survival estimates attained at 91%, while in patients with secondary mitral regurgitation attained at 71%. This difference was clearly driven by the deleterious effect of congestive heart failure in patients with secondary mitral regurgitation. Interestingly, in patients with primary mitral regurgitation with an age comprised between 80 and 89 years, 5-year relative survival estimate was 100%. In other words, their life expectancy was completely restored after TEER. While in patients with secondary mitral regurgitation aged 80 to 89 years, 5-year relative survival attained at 85%, so a little bit lower than patient with primary mitral regurgitation. Nonetheless, when considering patient with technical success of the procedure, this relative survival estimates increased at 90%, meaning that if we adequately treat our patient, the relative survival can approximate the expected survival.
So how do you account for the differences in outcomes in primary versus secondary mitral regurgitation? I mean, were there baseline differences accounting for the significant difference in the relative survival?
Yes, I mean, clearly when you stratify any population of mitral regurgitation patient according to the etiology, you basically split your cohort into 2 different completely cohorts with different clinical baseline characteristics and risk of adverse events. Nonetheless, despite significantly older age in patients with primary mitral regurgitation, as said, the mean age was 80 years in primary versus 76 years in secondary mitral regurgitation. 5-year survival and 5-year relative survival estimates were higher in patients with primary mitral regurgitation. This clearly reflects the prognostic effect of congestive heart failure and associated comorbidities in patients with secondary mitral regurgitation.
So, we discussed age quite a bit. Was age an independent driver of events in the Swiss registry?
I can answer this question referring to one of our previous population. So basically, in the whole cohort of patients enrolled in the MitraSwiss Registry, age, along with lower hemoglobin, increased creatinine, and decreased left ventricular ejection fraction were independent predictors of mortality at 5 years. When we refer to the present study, age was not an independent predictor of 5-year relative survival in the cohort of patients with secondary mitral regurgitation. We are working to investigate this aspect in patients with primary mitral regurgitation.
So how does the Swiss registry compare with other European registries? I know we talked about the MitraFR and the COAPT, but other more contemporary registries like the German TRAMI or the Italian GRASPIT trial.
Yeah, basically the TRAMI, the German TRAMI and the Italian GRASPIT are the 2 registries reporting long-term data of patients treated by TEER. The German nationwide TRAMI reported data on 780 MR patients with secondary etiology around 70% of the population, while the Italian GRASPIT registry reported on 304 patients with secondary etiology in 77% of patients. Survival estimates at 4 years were 47% in TRAMI and 52% at 5 years in the GRASPIT registry. Our registry reports data on more than 1,100 patients with secondary etiology in 45%, and our 5-year survival is 59%, so substantially in line with previous reports.
Yeah, so I think we're seeing consistent results when we're looking at particularly secondary mitral regurgitation in most registries. Do you think the results can be expanded to younger patients receiving transcatheter repair, perhaps as a bridge to more definitive therapies? I know this wasn't addressed very directly in your registry, but nevertheless, does it open the door for something like that in the future?
Actually, I mean, our aim is to be able to treat the vast majority of patients, but the design of the present study basically excluded patients aged below 60 because they were too few in our registry, and their clinical characteristics were so peculiar that were not basically comparable to the general population with same age and sex. What we believe is the main message that we can deliver to a potential audience with our study is that our results represent a further support to the adoption of transcatheter edge-to-edge mitral valve repair in the elderly, in particular in those aged 80 to 89 years, an age class with a high prevalence of mitral regurgitation and with a high risk of associated morbidity and mortality. This finding does not only apply to patients with primary mitral regurgitation, which showed a complete restoration of their life expectancy when analyzing the subgroup of patients aged 80 to 89, but also in patients with secondary mitral regurgitation, we observe a very high 5-year relative survival estimates of 85% that increased to 90% when considering patients with technical success. So this should somehow allow to consider much more the possibility to refer patient to TEER when patient present with symptoms and with an age comprised between 18 and 89 years.
Well, thank you very much. And I completely agree with you. We really shouldn't be extrapolating in populations that were not studied and not captured in the study. But congratulations on a fantastic trial. And thank you very much for dissecting it for us today. And it is reassuring to see very consistent results of transcatheter edge-to-edge technology for the mitral valve continue to be reproduced. So thank you, everybody, and hope you enjoyed this session with us.
Thank you, Mirvat, for your time.